patients with tetraplegia will likely have a therapist that they go to, both an OT and a PT, in an outpatient rehab center, and possibly somebody they see once a year, once every 2 years, to update their orthoses and their home program. However, occasionally there will be somebody with tetraplegia that will land in a hand and upper extremity rehab clinic. Maybe they've been independent for a number of years and they're being referred by their primary care physician or their neurologist. And those are the ones that we are going to talk about right now. So if they're at a hand and upper extremity clinic, it's probably because they need some advice with their hands or their arms. Maybe they have an orthosis that broke, or they're not using any kind of orthosis at all right now. Typically with tetraplegia, whether complete or incomplete, one of the bigger problems that will be seen is a lack of intrinsic musculature. It is the lowest innervated in the spinal column by C8 and T1. And so without the intrinsic musculature, again, you're going to have tight intermetacarpophalangeal capsules, so tight capsules, and you're going to have somewhat of an intrinsic minus looking hand, so flexed at the IP and hyperextended at the MP. And that's not functional in any respect. Now, is there function anyhow? Well, there often is function. If that capsule is maintained, and if the IPs are able to be open somewhat, many people with tetraplegia can still use a mobile arm support in conjunction with some sort of a quad-quip type orthosis with a universal cuff together so that they can still do some self-feeding, possibly shaving, and care on their hair. So there is, and remember, there's way more incomplete tetraplegias than there used to be. So there's going to be people that will have some remaining musculature. So it is important for us as hand and upper extremity rehab specialists to make sure that the hand has a position that is not flattened out and in an intrinsic minus type way, but in a more functional position with the capsules lengthened, MCPs in flexion, and IPs able to open. They don't need to be, now they're not actively opening, but passively. So the orthosis for resting and for night that we recommend it looks something like this. Now, this orthosis was custom made, and the way that it's custom made on somebody that has, let's say like C5 or C6 tetraplegia, first do the hand component and then do the forearm component. And that's the way that this one was fabricated. So for the hand component, you're going to start with a rectangle, and the rectangle will lay directly over the patient's hand with their hand you'll have to place it into this position as maximum as you can get. And then you're going to lay that rectangle over the top. Then you'll cut out a space for the MCP heads to come through, to dorsally peek through. Why do you need that? Because otherwise they will fall out of it. You need to have that counter pressure, like it becomes a 3-point counter pressure orthosis. For the palmar bar, for this hand piece, you're going to roll the orthotic material. You're going to roll it right over a strap. So I narrowed this strap before I rolled it in there, but then I rolled it over and then I fit it very carefully to my patient's hand to maintain that transverse palmar arch, to maintain all 3 arches of the hand. So then it velcros on like that. So that's how it will look. Now you can separately put that aside, separately fabricate the more proximal piece, which is really just a long bar. So it's not dissimilar to this quad-quip orthosis or this other newer modified version of a quad-quip orthosis that has better surface area. It's very similar. So you're going to mold that, then you're going to melt these together with the heat gun and possibly a little bonding agent. Now, when the patient, let's say that they have more function in their left than their right, or maybe they have a little function in both, sometimes a loop, like the one I'm using now, will do it so that they can loosen it and tighten it on their own. This is another way to make a loop. You take the hook Velcro and let me take this one off to show you better. And you make a strip with the loop with the hook Velcro, and you put just a small piece of loop Velcro on a portion of it so that they don't have that spiky stuff hitting them in the skin. And that's just another way to do a loop. So I wanted to show those loops, both the cutout like this as well as the other one, as a simple way to make a D-ring so that the patient can better adjust these orthoses on their own, even if they're not putting them on completely on their own or taking them off. Now, of course, this one wasn't made on me. I'm kind of swimming in it, but basically the idea is that it's holding my MCPs in flexion. My IPs naturally will extend a little bit with my MCPs in flexion, but the IPs can be free. And then the palmar arches are maintained by that palmar bar. Now, this would be worn at night, but also during the day. And while the patient's in their chair, you're going to have them positioned with the IPs flexed, and they can learn to do this themselves by retracting their shoulder and then just pushing their IPs into flexion. So I'm just retracting my shoulder, and then I'm going to protract, and my IPs passively go into flexion. And that's a good way to rest. Now you'll notice that the thumb is not in this orthosis at all. Sometimes we leave it out. Other times we will take a piece of orthosis material and just very gently keep it in there. But with tetraplegia, the object is to get, if there is going to be a pinch at all, even with tendon transfers down the line or nerve transfers, the objective would be to get a good strong lateral pinch versus a palmar pinch. So the thumb should be placed laterally so it is a little bit tighter. Here's one case where you don't want a large web space. You want it to be nice and tight here, a little bit adducted, so that you can have so the patient can have a stronger lateral pinch. If with tendon transfers, the goal is to take advantage of a tenodesis and come up into a lateral pinch.
Patients with spinal cord injuries have some unique splinting needs that we're going to talk about now. A lot of patients with C5, C6 are going to end up with an intrinsic minus hand. As they lose those lumbricals and the interossei, they're going to end up with an intrinsic minus hand, like Miranda has here. You end up with MCPs that are extended and IPs that are flexed. And if left for a long period, that can get contracted. You can get joint contractures in that position. And muscles, the extrinsics can begin to get tight and fixed in position. So we want to prevent that from becoming a long-standing contracture position. So we're going to work on a splint today that's going to show you how to kind of keep that. That's going to be a resting splint and a nighttime splint. If you want to do therapeutic exercises outside of it, you can take it off for that. They're home program things. But this is going to help them gain some function and keep them from getting stuck in that position. So there's 3 parts to this one. The first part is a square where the window of that is just barely inside the width of her MCPs. And I do just barely inside because it's going to stretch it a little bit. And if I make it the full width, it's going to sag on her. And it basically runs from the PIP dorsally to where the wrist crease is if it was opposite the distal wrist crease, okay? So that's the size of my window. So if I were to flip this over on her, you can kind of see here how that would go. If the MCPs dorsally are here, it's from PIP to, on the back side, it would be about that wrist crease there. So about where we are here, that's our size is going to be. I'm going to put that in. We're going to make that first, but almost. So I'm going to put this in the heat now. And then I'm going to pull out what is going to be a palmar bar that goes in that palm that's going to help hold this into that volar part of the MCPs. I've taken a strap and already tapered it down because I'm going to take a rectangle that is the width of her hand and roll it around that and make a good solid bar on it. So I'm going to take my piece here, it's hiding, and that is roughly the width of her hand. So if I take her hand this way, roughly the width, maybe minus a hair, okay? I'm going to take that and roll it, okay? And I'm going to make kind of a tight little roll here, okay? Now, still very formable. Because I've doubled it up on itself, it's going to cool a little slower. I want the Velcro to be to the point where I can stick it on the back, so fuzzy side down. And I'm just going to kind of tack her hand here, and I'm going to work to maintain that transverse longitudinal arch that we've got. And so I'm going to kind of push that down there because that's going to help push her into that splint, okay? So as I'm making that, I'm just kind of forming that in there. And like all of our Taylor splint style splinting materials, once I've got kind of a base there, I can take it off and it'll continue to harden on its own, but not lose its shape like some of our more drapable materials. And with our spinal cord patients, I prefer to have something that's not perforated. I want a very smooth, uniform surface, and it means I don't have to put the extra stuff like the edging on and that kind of stuff, because it doesn't wear as well. They're gonna have this a super long time, and it may cause some skin integrity issues if that moisture were to stay on them if they get a little sweatier. So I can take that off, and you see I'm trying to keep that arch system to her hand, both transverse and longitudinal. I may even kind of encourage a little bit more there, kind of set that back on, make sure she's got that good arch pattern developing there. I'm going to take that and set it aside and let it cool in position. Again, because I doubled it over on itself, it may not cool as quickly, so I'm just going to leave it there. It's going to set and be just fine. So to make this next part, I'm going to put her hand into a gentle fist, okay? Relaxed right there. I want to get as much MCP flexion as I can. If she's already got some contractures, I may not get all the way, but as much as I can. I'm going to take this material, that little square with a cutout we talked about. I put it in the heat first, cut out the rectangle on the inside, and then so it was softer, and then I put it back in again so it's nice and relaxed for us, okay? So I'm going to, in this case, I'm going to have her bring her hand up just a little bit there, okay? And I'm just going to go there. And that's going to work to hold her down, okay? Hold her into that MCP flexion position. And I'm making sure I've got good ulnar and radial borders here. And I'm going to go ahead and just do a little bit of contour around the fingers so it's a little clearer when it's time to put it on where those digits go. Just a little bit there. And we'll let that harden for a minute. I'm going to put another piece on underneath, and it's already in here, but it's basically just a simple rectangle that I pre-cut that's going to go from just proximal to MCPs to 2/3 the forearm. And it's just a simple rectangle. I kind of took a scrap piece and it's a little off on the edges. I may trim it down a little bit. That's going to go between here and her hand. It's going to slide underneath there. So this doesn't even have to be perfectly formed because I'm putting something underneath there. Okay, so now it's solid enough, I can take it off. I'm not gonna mess with it a ton, but like that other piece, I can set that there, and it's gonna harden and be the right shape. Now, super simple, take this little rectangle I have out of here, dry it off, and this is just a simple forearm piece that's gonna go dorsally on her. And like we've talked about this material, I'm gonna let the air hit it and kind of let it cool. As soon as I put it on her, her body temperature keeps it up. So we wanna make sure that's cooled a little bit, make sure I don't burn the patient because they may not have great sensation and know that it's too hot, okay? So we keep her in that same gentle fist. And like we talked about, just going proximal to that MCP crease. And we're just gonna let that form there, okay? While it's there, if I want, I can go ahead and drop some of these on here. Okay. I'm only going to do 2 because the other one is going to go over the top of this so it's a continuous piece. In general, we want fewer little dots because on a continuous piece you can pull from the middle and the edge doesn't pull up there. So we want to do fewer of those little dots. And I'm just going to make sure it tapers around her there, and we'll wait for that to harden. When it's solid and ready, I'm going to score this and where this overlaps it. So I can even set that back on there now and say, okay, here's my little line that is where I'm going to score. Because this Taylor splint material and some of the other materials like this, they don't bond as well. They've got a coating on them so they don't bond. So I'll take some scissors and kind of scuff that up. I'll do it with my nail here just so you get the idea, but I'll take some scissors and scuff that up. And then I do the same thing on the bottom side of this. Maybe I open those scissors, do it over a cutting board. We're a big fan of that. But I'll just spend some time kind of cross-hatching this. I'll go all the way down one way, and then I'll go the other way. Open that up, basically taking that, that coating off of it. And then you can use the bonding agent or solvent if you have it, if you've got that handy.
You can also use a utility knife to...
Yep. Always working over a cutting board and scoring away from yourself, not towards yourself. Okay? Away from your hand, away from your fingers, not towards the thumb. Okay? So I'll adhere those. We'll use the heat gun and I'll get those to bond. Okay, so we heated it with the heat gun. After we scored it, pressed it together, I would probably use a solvent or something for sure, just to make sure that this long-term splint for the patient stays together well. I'll put another piece of Velcro across here. We make this in 2 pieces because it's a little difficult and tricky sometimes to make a splint on a spinal cord injury patient, just to get the MCPs at the right angle and do it all in one shot. So it kind of helps to make it in 2 pieces. That means I can get the MCPs at a great position and then make the other piece, put it together, and we know it's in a better end product. The window here, you could make this as one solid piece, but you never really know if you've got the MCPs high enough up. This allows me to make sure I'm pushing those MCPs up into that window, and then I can see that I've got good flexion and they're popping up through that window in a great way. So I've got our straps there, and just because it's a little trickier to splint our tetraplegia patients, this is kind of a helpful thing to do. So we've got a couple strap options here. I'm going to put a proximal strap on. Now, some of our straps here I want to be a little long because I can do a loop here that I cut into it that can allow them to pull that off. But I want that, actually put that the wrong direction. I want that medially so that they can pull that off towards themselves, pulling it in, and then same thing, putting it back on. If they have to go across their body, that's a little trickier. So we'll do that. Same thing here. I'll come around this direction. Okay, leave that there. This palmar bar, now that it's all set, remember the convex portion goes in the palm, I put a different kind of D-ring on because this is a narrower strap. What I did was I took non-sticky back hook Velcro, put a little piece of the red non-sticky back loop Velcro in the middle of it so they don't get the scratchy on them. And then I just kind of tacked what's left over on there and kind of made an extra D-ring, and I can put as much space there as I need to. So I'll put that inside her palm. Okay. And I get this one anchored. Oops. There we go. And now this one pulls across. And then she's got that D-ring. So she's got 3 kind of custom fabricated D-rings. And I want to make sure she's nice and anchored in there. So I might loosen and kind of reset that a time or 2, make sure she fits in there well. And remember, our goal for this is to prevent that intrinsic minus hand. So now the fingers, the IPs can go into extension, but we have more tension on some of those other muscle groups, so we're not going to end up with that hyperextension and flexion there. So we get some extension of the IPs and flexion of the MCPs. And if we want to work on flexion more so, or extension of those IPs, we can do this where we teach the patient to drag the arm back and then gently push forward into flexion. And that's a good back and forth, and then resting with those fingers in flexion puts tension on the extensors, so we get maybe a little bit more tenodesis happening when they do that wrist extension. The finger flexors are not overstretched because the IPs have spent too much time in extension. So we want them to rest by, they may pull back and then get their hand into a little bit too far back and then just gently push forwards. Now their hand's in a good resting position. We've left the thumb out of the splint. A lot of times we'll do that depending on what activation they have in the thumb. If we feel like we need something to keep that thumb from being too abducted, remember, we want a lateral grasp. You don't want a big giant web space there. We want it to be a little tight so that tenodesis gives them a lateral grasp. So I might put a little extra piece here, like a little L shape or like a hockey stick shape that kind of holds that thumb in to keep it from stretching out too far. But it's just like a block that holds them from coming out too far. You may not even need a strap on it. You take away the functional grasp if you do put a strap on it. So maybe a thumb piece is necessary, but otherwise, that's our splinting for a roughly C4, C5 tetraplegia patient.